So, uh, when you picture a humanitarian crisis, what is the very first image that flashes into your mind?
Yeah, if you're like most people, you're probably imagining, the Hollywood version.
Exactly, the Hollywood version. You picture trauma surgeons in green scrubs
Right.
rushing a patient on a stretcher through some dusty compound with sirens blaring in the background.
Sirens, helicopters, the whole thing.
Yeah, you imagine sudden explosive outbreaks of infectious diseases like cholera or Ebola, and
Yep.
aid workers urgently passing out emergency food rations from the back of an armored truck. It's all very fast, very acute, and, well, very bloody.
It is. It's a visceral, highly dramatic image. And certainly that acute trauma response, stopping the bleeding, containing the infectious outbreak, that is a vital non-negotiable part of humanitarian aid.
Right, of course.
But if you look closely at the data from modern crises, that dramatic, bloody image is really only a tiny fraction of the actual reality on the ground.
The reality is much quieter and arguably much more insidious. So today, we are taking you on a journey to explore a profound, yet, almost entirely invisible shift in global health and humanitarian aid.
It really is a massive shift.
Yeah. And we are basing our conversation on a stack of deeply researched sources today. Specifically, a comprehensive policy brief on integrating non-communicable diseases, or NCDs, in emergency preparedness, and a detailed paper outlining the, frankly, brutal operational considerations for managing these NCDs in humanitarian settings.
Yeah, the data in these pages, it completely shatters our traditional understanding of emergency aid.
It really does. So what's the mission for this deep dive? It's to reveal this hidden crisis.
Because to understand the scale of this, we really have to look at the baseline of global mortality. According to the World Health Organization, 74% of all deaths globally are caused by NCDs.
Wait, 74%?
74%.
Yeah.
Yeah. We are talking about cardiovascular diseases, high blood pressure, diabetes, chronic respiratory diseases like asthma and cancer.
That is, think about that for a second. We spend so much time worrying about the next sudden pandemic or the immediate casualties of a natural disaster, but nearly three-quarters of all human mortality is driven by chronic conditions.
Right. Which brings us to the central, terrifying question of our discussion today.
Right. What happens to someone who is completely dependent on daily insulin, or someone who needs weekly renal dialysis when a war breaks out and their city is reduced to rubble?
Or what happens when a massive earthquake destroys the only pharmacy or clinic for 100 miles?
It's a logistical nightmare.
It is a complete medical nightmare. So today, we're going to connect the dots between high-level global policy frameworks, the grim, unvarnished realities of real-world conflict zones, and your own understanding of what it actually means for a healthcare system to be resilient.
Okay, let's unpack this. Because to truly understand the sheer scale of this hidden crisis, we have to look at how the global health community is fundamentally redefining what a humanitarian emergency even is.
Yeah, the numbers laid out in these documents are just mind-blowing.
They really are. Based on 2018 data, the global burden of NCDs is 41 million deaths annually. And here's the part that really stopped me in my tracks. 17 million of those are premature deaths, meaning people dying under the age of 70.
And overwhelmingly, these premature deaths are happening in low and middle income countries.
Which is such a critical point.
It's the linchpin of this entire issue, really, because these low and middle income countries, or LMICs, are the exact same regions where the vast majority of humanitarian crises, armed conflicts, and climate-driven disasters are occurring.
Right, they overlap perfectly.
Exactly. And the health systems in these countries are often already incredibly fragile. During peacetime, they might just barely be managing to provide baseline NCD care.
Like a patient might have to travel hours just to get a basic blood pressure medication.
Exactly. Then you introduce a crisis, a sudden armed conflict, a devastating flood, or an earthquake. And that already fragile system doesn't just struggle, it completely and totally collapses.
And we aren't just talking about a few people being temporarily displaced for a few weeks while the floodwaters recede. The sources state we are currently witnessing the highest level of human displacement in recorded history.
The numbers are staggering.
Over 62.5 million internally displaced persons, or IDPs. Those are people forced to flee their homes, but who, remain trapped within their own country's borders.
Plus, you have another 35.3 million refugees who have actually managed to cross international borders.
We are looking at nearly 100 million people on the move, carrying their chronic illnesses with them.
Yeah, the sheer volume of people is one thing, but what has fundamentally broken the old model of humanitarian aid is the duration.
The length of time they are stuck.
Exactly. Historically, the humanitarian response was built, conceptually and logistically, for short-term, acute crises. Think back to the origin of organizations like the Red Cross or Doctors Without Borders.
Right. The goal was to rush in, stop the immediate cholera outbreak, treat the acute gunshot wounds.
Stabilize the population with basic calories and water, and then leave when the political crisis subsided or the immediate danger passed. But the nature of displacement has fundamentally changed. The average length of displacement is now 20 years for refugees.
Wait, 20 years?
20 years. And for IDPs, it is 10 years.
I really want to make sure you, the listener, hear that number. 20 years. That is an entire generation. That means a child could be born in a refugee settlement, go through their entire childhood, enter adulthood, and have their own children entirely within a state of displacement.
Yeah, we still use the word camp, which implies something temporary, like setting up tents for a weekend.
Right, but a 20-year camp isn't a camp. It's a makeshift city.
It is. And furthermore, displaced populations are increasingly settling in actual urban areas rather than those traditional isolated tented refugee camps we often see in historical news footage.
Oh, interesting. So they are moving into the margins of existing cities in neighboring countries.
Exactly. And these protracted long-term crises are increasingly impacting middle-income regions. Look at the Middle East, for example.
Yeah.
You have populations there that already have a much higher baseline prevalence of NCDs, heavily driven by lifestyle, diet, and genetics.
So when a crisis hits a middle-income country, you aren't just dealing with malnutrition.
No, you are dealing with thousands of displaced people who suddenly cannot access their hypertension medications or chemotherapy.
Okay, if I can try to visualize this, it sounds like we've been treating humanitarian aid like a sprint, rushing in with trauma kits and bandages, but the reality on the ground has turned into a marathon, and we forgot to bring water and long-term supplies.
That is a very accurate analogy. The tools simply don't match the disease anymore.
Let me push back for a second, though. I am trying to put myself in the shoes of a field director in a crowded, chaotic refugee settlement, maybe one where the sanitation infrastructure has totally failed. Surely infectious diseases like cholera, measles, or dysentery spread like wildfire in those conditions. They can literally wipe out thousands of people in a matter of days. If I have limited resources, why should chronic, slow-moving conditions like diabetes or high blood pressure take equal priority when I have explosive, highly contagious outbreaks to deal with?
What's fascinating here is that you are falling into the trap of thinking about chronic diseases as slow-moving.
Oh, are they not?
In a normal, stable environment, yes, they are slow. But a humanitarian crisis acts as what the sources call a risk magnifier. It is not an either situation between infectious and chronic diseases. The crisis actually takes these slow-moving chronic diseases and makes them violently acute.
How exactly does that biological shift happen? How does a slow disease become fast?
Think about the physical and psychological conditions of sudden displacement. You have immense, overwhelming psychological stress and trauma. People lose their homes, their entire livelihoods, their communities, and sometimes their family members in an instant. Biologically, that level of stress floods the body with cortisol and adrenaline. The sympathetic nervous system goes into overdrive. Now, combine that with a sudden shift to a poor diet. They are surviving on emergency food rations that are often highly processed, packed with sodium and simple carbohydrates just to maximize caloric intake.
Just to keep them from starving.
Right. Their physical activity is severely restricted because they might be confined to a small area for safety. And quite naturally, people turn to coping mechanisms to deal with the trauma, leading to increased tobacco or alcohol use.
So you take someone who already has some plaque in their arteries or maybe borderline high blood pressure and you subject them to maximum stress, high sodium, and restricted movement.
Precisely. All of these factors combined are massive acute triggers. They cause sudden cardiovascular events like massive heart attacks or severe strokes in people who, back in their normal lives, were managing their underlying conditions perfectly well.
Wow.
The stress of the conflict literally breaks their cardiovascular system. And that is before we even talk about the supply chain.
Right, the sudden, abrupt cutoff of essential medications.
Take a person with type 1 diabetes, whose pancreas produces zero insulin. If they are displaced and cannot get their insulin, they don't just feel a little unwell.
What happens?
Their blood sugar spikes, their blood turns acidic, they go into diabetic ketoacidosis, and they can fall into a coma and die in a matter of days.
That is definitely not a slow death.
No, it is an immediate, highly preventable, acute death caused directly by the logistical disruption of the crisis.
So the distinction between an acute injury from a bomb and an acute medical crisis from a lack of insulin is virtually non-existent for the patient. I mean, both will kill you this week.
Yes, exactly. NCDs in these settings require both immediate life-saving interventions to prevent those acute events and the establishment of long-term management protocols.
You know, to really grasp how quickly an NCD crisis can unfold when a massive, complex health system is suddenly overwhelmed, we don't even have to look at a distant war zone or a theoretical earthquake.
No, we don't.
We all lived through a universal, perfectly scaled example of this quite recently, the COVID-19 pandemic.
Oh, absolutely.
As I was reading through the documents, they explicitly frame the COVID-19 pandemic as a microcosm, like a global, protracted humanitarian crisis specifically tailored to devastate people living with NCDs.
It is the absolute perfect parallel to understand the mechanics of what happens in a conflict zone. Think back to the early months of 2020.
Yeah.
The pandemic forced every health system on the planet, even the most robust, well-funded systems in the wealthiest nations, to rapidly pivot and prioritize a short-term emergency response over pre-existing long-term health needs.
Hospitals were rapidly converted into dedicated COVID wards.
Right. Elective surgeries, which often included crucial cancer biopsies or cardiac procedures, were canceled en masse. Routine preventative care was entirely suspended.
And the outcomes of that suspension were devastating. We all saw the data as it came out. COVID-19 outcomes were significantly, demonstrably worse for people who had pre-existing conditions.
Much worse.
Yeah.
We are talking about folks with diabetes, coronary artery disease, chronic obstructive pulmonary disease, or COPD, and obesity.
If you had an NCD, the virus didn't just infect you. It hit you much, much harder, exploiting the existing weaknesses in your immune and vascular systems.
And we must recognize that the danger wasn't just the viral pathogen itself, It was the global systemic response to the virus.
The lockdowns.
Yeah, the lockdown policies, while completely necessary from an infectious disease control standpoint, inherently increase NCD risk factors on a planetary scale. Hundreds of millions of people were confined to their homes, which drastically restricted physical activity.
Global supply chains broke down, making it harder and more expensive to access fresh, healthy foods, pushing people towards shelf-stable, highly processed options.
Exactly. The very public health measures taken to slow the infectious disease inadvertently poured gasoline on the fire of chronic diseases.
Here's where it gets really interesting. The WHO Director General actually went on record and said that COVID-19 preyed on people with NCDs.
That's a strong word. Preyed.
Right. I mean, think about the weight of that phrasing. It wasn't just a statistical coincidence. It was an active exploitation of vulnerability. In a rapid assessment conducted by the WHO in May of 2020, they surveyed 163 governments. 75% of those governments reported significant disruptions to at least some of their NCD services.
75%.
And the areas most heavily and immediately impacted were rehabilitation and palliative care.
We need to pause on what disruption to rehabilitation and palliative care actually means in human terms.
What does it look like on the ground?
It means the stroke survivor cannot get the physical therapy they need to learn how to walk again, permanently cementing their disability. It means the terminal cancer patient cannot get adequate pain medication, forcing them to spend their final weeks in agonizing pain.
It is a profound loss of human dignity.
It is. And then, layered on top of the medical breakdown, you have the devastating economic fallout. The World Bank estimated that 97 million more people were pushed into extreme poverty globally in 2020 alone.
So even in scenarios where the pharmacy down the street actually managed to keep the blood pressure medication or the asthma inhalers in stock, suddenly the patient who just lost their job due to the lockdowns couldn't afford the out-of-pocket costs to buy it.
Exactly. The medication is sitting right there on the shelf, but economically, it might as well be on the moon.
If we connect this to the bigger picture, this is exactly what displaced people experience in conflict zones every single day, just scaled down to a regional level.
Yes. The supply chain breakdowns where the trucks can't get through the borders, the physical inability to travel to see a doctor because the roads are unsafe or littered with checkpoints.
The sudden plunge into profound poverty that makes purchasing life-saving daily medication an impossible dream. During the pandemic, the entire globe got a very bitter, very real taste of the daily reality for a refugee living with an NCD.
It really reframes the whole concept of what a disaster actually is. The disaster isn't just the virus or the bomb falling from the sky or the floodwaters rising.
It's the invisible architecture of the system, failing the people who rely on it to stay alive every single day.
Precisely.
So this forces us to confront a really dark, difficult reality. Let's get down to the operational grit here. If the health system is failing, the supply trucks are bombed, and resources are completely overwhelmed, how do doctors on the ground actually decide who gets the limited NCD treatments that are available?
That is the big question.
We have to talk about triage, ethics, and some truly impossible, agonizing choices.
It is, without a doubt, one of the most agonizing and morally complex aspects of humanitarian medicine. Humanitarian interventions, by their very definition, always have to be prioritized. You never have everything you need.
Right, there's no endless budget.
No, you have strictly finite resources, a finite number of trained doctors, a finite amount of money from donors, and a finite logistical capacity to move refrigerated boxes of medicine. And you have to weigh those incredibly limited resources against the sheer disease burden of the population.
And the severity of the consequences if a specific condition is left untreated. It's basically the ultimate trolley problem, but with real human lives. The documents we reviewed point to an informal working group that actually sat down and identified a specific evidence-based list of priority NCDs for these crisis settings.
Yeah, they didn't list everything.
Right. They specifically highlighted cardiovascular diseases, high blood pressure, asthma, COPD, epilepsy, and diabetes. But even within that highly prioritized list, the day-to-day triage reality is just brutal.
To truly understand the mechanics of this triage, let's look closely at diabetes because it provides a very clear, stark contrast.
Okay, let's hear it.
Imagine you are a clinician in a newly established refugee camp. You have two patients in front of you. Patient A has type 1 diabetes, which means their autoimmune system has destroyed the beta cells in their pancreas. Their body produces absolutely zero insulin.
Okay, so they need it injected daily.
Right. If patient A loses access to exogenous insulin for just a few days, their blood sugar will skyrocket, their blood will become dangerously acidic, and they are at a massive immediate risk of falling into a coma and dying.
And patient B?
Now look at patient B. They have type 2 diabetes, where their body still produces some insulin, but they are insulin resistant. Patient B has been managing their condition reasonably well with oral medications like metformin and diet.
Okay.
If patient B's oral medication is disrupted for a few weeks or perhaps even a couple of months, their blood sugar will rise and they will feel lethargic and unwell. But they are highly unlikely to suffer an immediate, acute, fatal consequence in the short term.
So if I am looking at my inventory and I only have a small, dwindling amount of resources, the type 1 diabetic gets prioritized, no questions asked, because they will literally die tomorrow without intervention.
Yes.
Whereas the type 2 diabetic, as harsh as it sounds, is told to wait.
Yeah.
They can survive the temporary disruption, even if we know medically that the disruption is actively harming their long-term vascular health.
That is the grim reality of emergency triage. It is a system entirely based on life-saving priorities and the immediate relief of suffering in the acute phase of a crisis. You are triaging for survival, not for optimal long-term health. But this ethical tightrope gets even more complicated and arguably more painful when we talk about resource-intensive treatments.
You mean like complex therapies?
Yeah. Cancer chemotherapy, radiation, or end-stage renal dialysis.
Yeah.
The operational guidelines we are analyzing are very clear, almost blunt, in stating that providing these types of complex treatments is rarely sustainable or appropriate for short-term humanitarian agencies to take on.
Let me stop you there, because I think a lot of listeners might bristle at that.
Sure.
If I am a humanitarian worker on the ground and I have a finite budget, let's say $100,000 from a donor, how do I legally or morally justify spending $80,000 of it on one single patient's highly expensive, highly complex, multi-month cancer treatment when I know that exact same amount of money could buy basic antibiotics, oral rehydration salts, or water purification tablets that could save 5,000 children from dying of dysentery?
This raises an important question, and it cuts to the absolute core of humanitarian ethics. What you are describing is the fundamental tension between a public health approach and an individual clinical health approach.
Right.
In severe emergencies, the public health approach, which dictates doing the greatest good for the greatest number of people with the resources available, has to take precedence. You have to save the 5,000 children.
That makes logical sense, even if it feels awful.
But there is a deeper layer to this, and it is deeply tied to the foundational medical principle of do no harm.
Wait, how does treating someone's cancer or hooking them up to a dialysis machine violate the principle of do no harm? Surely denying them the treatment is the harm.
It seems counterintuitive, but think about the logistics. Enrolling a patient into a complex long-term program or a lifelong therapy like renal dialysis carries an immense ongoing financial and ethical responsibility.
Okay, follow the timeline.
Let's say a short-term NGO arrives after an earthquake and sets up a dialysis clinic in a temporary refugee camp. They start treating a patient whose kidneys have failed. What happens when that NGO's emergency mandate ends in 6 months, their funding dries up, and they have to pack up and leave?
Oh.
Or what happens if the conflict escalates and the NGO is forced to evacuate for security reasons, the dialysis stops. And the patient, who has now become entirely dependent on that machine for survival, will die a very painful death shortly after the NGO leaves.
You have initiated a life-sustaining treatment without the ability to guarantee its continuation.
Exactly. You have offered false hope and ultimately abandoned the patient. Therefore, the strict guidelines state that these complex, resource-heavy cases must be referred to second- or third-level national hospitals outside the crisis zone whenever humanly possible.
And what if that referral simply isn't possible? What if the borders are completely closed to medical evacuations, the national hospitals have been bombed to rubble, and the patient is trapped in the camp?
Then the focus of care fundamentally shifts. The documents stress, with absolute urgency, that supportive and palliative care must be provided at every single stage of the response.
So making them comfortable.
Right.
Yeah.
Even if the harsh reality of the logistics dictates that you cannot provide life-sustaining curative treatment like chemotherapy, you still have a profound moral obligation to ensure dignity, manage pain, and provide relief from suffering.
You provide morphine, you provide psychological support, you provide a clean, quiet space.
It is a heartbreaking reality for clinicians who are trained to cure, but it highlights exactly why the overarching long-term strategy for NCDs in emergencies has to be entirely focused on primary health care, or PHC. We have to maintain broad essential benefit packages at the community level rather than setting up what we call vertical single disease programs.
Can you explain that distinction? What is a vertical program versus primary health care in this context?
A vertical program is an intervention focused narrowly on a single disease. For example, a massive foreign NGO comes in and sets up a state-of-the-art clinic that only treats HIV or only treats tuberculosis.
Okay.
They have their own supply chains, their own highly paid staff, and they operate completely outside the host country's normal health system. When the NGO leaves, the vertical tower collapses because it was never integrated.
Right, because it was in a silo.
Exactly.
Yeah.
Primary health care, on the other hand, is horizontal. It is the foundation. It means training the local community clinic to handle basic maternal health, basic infectious diseases, and basic NCD management like prescribing blood pressure pills and checking blood sugar all in the same room, using the local workforce.
That makes perfect sense. You want to pour a solid concrete foundation that serves everyone, not build a fragile, specialized tower that falls over the minute the wind blows. And the sources provide a brilliant, tangible example of this from Pakistan, specifically in the region of Muzaffarabad. The data presented here is legitimately shocking. In 2016, at a physical rehabilitation center in Muzaffarabad, over 15% of all lower limb amputations were related to complications from diabetes.
Yeah, think about the context of that.
This is a region that has seen intense conflict and massive earthquakes. But these amputations weren't from stepping on landmines. They weren't from being crushed by earthquake debris. They were from diabetes.
That statistic perfectly and tragically illustrates the hidden long-term toll of unmanaged NCDs in a fragile setting.
Yeah.
Let's look at the pathophysiology for a second.
Break it down.
A patient with poorly managed diabetes often develops peripheral neuropathy. They lose sensation in their feet. They might step on a piece of glass or get a blister while fleeing a conflict, and they literally don't feel it. Right. Because their blood sugar is high and their circulation is poor, that tiny wound doesn't heal. In a crisis setting with poor sanitation and no access to basic antibiotics or wound care, that ulcer quickly becomes infected, turns gangrenous, and the only medical option left to save the patient's life is amputation.
It is a devastating, permanently disabling, and entirely preventable outcome.
Entirely preventable.
So if you are an aid organization looking at that data, the instinct might be to bring in more orthopedic surgeons, build more surgical theaters, and manufacture more prosthetic legs to handle the volume of amputations.
Which is the old way of thinking.
Right. But the International Committee of the Red Cross, the ICRC, looked at that data and took a completely different horizontal approach. They realized the amputations were just the terrifying symptom of a failed primary care system.
Exactly.
So they worked directly with the local health authorities to decentralize diabetes care. They moved the treatment out of the specialized hospitals and pushed it all the way down to the primary care level, right into the community clinics.
Which is brilliant. They trained the local nursing staff on diabetic foot care. They provided simple point-of-care diagnostic devices to check blood sugar instantly. And they heavily engaged the community to focus on prevention and early detection.
They targeted the root cause at the primary level to stop the ulcer from ever forming, preventing the amputations from happening in the first place.
It is a masterclass in health system strengthening. It is a textbook example of integrating NCD care seamlessly into the existing local health system rather than bypassing it. But we have to acknowledge a major logistical hurdle here.
That's that.
To execute this kind of effective primary care on the front lines, to actually check the blood sugar and treat the ulcer, those local health workers need physical tools. They need standardized equipment, diagnostic devices, and medications.
Oh, right.
And surprisingly, if you rewind just a decade ago, a comprehensive, standardized toolkit for this simply did not exist in the humanitarian space.
This is one of the most fascinating operational details in the documents. For decades, the standard emergency response in the humanitarian world relied on something called the Interagency Emergency Health Kit, or the IEHK.
Right.
Whenever a major disaster struck a tsunami, a massive earthquake, a sudden refugee influx, huge cargo planes would fly in crates of these standardized kits. But these kits were almost entirely geared toward trauma and infectious diseases.
Yeah, they were packed with massive quantities of bandages, surgical tools, intravenous fluids, and broad-spectrum antibiotics.
But NCD medicines and basic chronic care technologies like simple blood glucose test strips or asthma inhalers were glaringly absent. You would have a crate of top-tier surgical equipment, but absolutely nothing to offer the grandfather having a massive hypertensive crisis or the child whose asthma is triggered by the dust of collapsed buildings.
That historical gap in the emergency supply chain was a massive, lethal blind spot. The entire system was suffering from a collective failure of imagination, assuming that chronic diseases somehow paused during war.
But the landscape changed significantly, and quite recently, when the WHO Eastern Mediterranean region spearheaded the development of the WHO NCD emergency kit.
And to be fair to history, this was built upon a vital prototype called the Balkans kit.
Right. The documents mention that?
Yeah, the Red Cross developed it during the Yugoslav wars in the 1990s when they first realized they were dealing with a displaced European population heavily burdened by cardiovascular disease.
The modern WHO NCD kit was first officially deployed in Syria in 2017, right in the thick of a horrific, protracted conflict. And the pure logistics of this kit are fascinating to me. It's not just a random assortment of pills. It is mathematically designed.
Completely standardized.
A single kit provides a standardized, rigorously calculated quantity of essential NCD medicines. Insulin, blood pressure meds, asthma inhalers, designed to cover the baseline needs of a population of 10,000 people for 3 entire months.
The development and successful deployment of this kit represents a massive logistical triumph, especially overcoming incredibly complex cold chain requirements to keep insulin viable in a war zone.
That alone is amazing.
But more importantly, it represents a profound psychological paradigm shift in global health. By creating a standardized, prepackaged, globally recognized module specifically for chronic diseases, the global health community was finally formally acknowledging a hard truth.
And that providing a beta blocker for hypertension or an inhaler for asthma in a refugee camp is just as vital and just as life-saving as applying a tourniquet to a gunshot wound or hanging an IV bag for a cholera patient.
Exactly. It legally and operationally elevates NCDs to the exact same level of emergency priority as acute trauma.
I love looking at it as a chronic illness life raft. Imagine the chaos of a sudden disaster. Tens of thousands of people are displaced overnight. Under the old system, aid workers would have to scramble, making wild guesses, trying to mathematically calculate what a random population of 10,000 terrified people might theoretically need for their specific heart conditions, lung diseases, and thyroid problems.
It would take weeks to procure.
Weeks. Now, you bypass all that math. You just drop in this standardized pre-calculated kit, and you instantly stabilize the community's baseline chronic health needs while you figure out a longer-term plan.
And this monumental shift in thinking wasn't just about physical boxes of medicine. It was actually codified into the very rules of humanitarian aid.
In 2018, the Sphere Handbook was officially updated. And for those who don't know, the Sphere Handbook is essentially the operational Bible that dictates the absolute minimum standards for humanitarian response.
Right, and it formally included comprehensive guidelines for NCDs and palliative care. placing a massive, bolded emphasis on preventing the sudden disruption of treatment for patients who are diagnosed before the crisis hit.
The inclusion of NCDs into the Sphere standards cannot be overstated. It is huge because the Sphere Handbook isn't just a suggestion, it sets a globally recognized benchmark for accountability.
If an NGO claims to be providing comprehensive healthcare in a crisis, and they are not meeting the Sphere standards for NCDs, they are failing.
Plain and simple.
And we can see exactly how this standardized, accountable approach works in practice on the ground. Look at the pilot project launched by the WHO in Afghanistan.
Yeah.
The health system there is incredibly strained. The WHO supplied 27 of these standardized NCD kits directly to primary care centers that were supported by the Afghanistan Red Crescent.
And how did that go?
The kits proved to be an incredibly effective entry point. Because the essential medicines and diagnostic tools were physically right there in a box, readily available to the clinicians, it made it operationally feasible to rapidly embed NCD services into the country's essential package of health services.
You can't train a nurse to treat diabetes if you don't have the insulin to give her. The kit solves the hardware problem so the training can actually work.
Exactly.
But a kit is still just a box of medicines sitting on a shelf. It doesn't administer itself, and it doesn't know who needs it. How do you build a resilient, intelligent system around that box so that the vial of insulin actually reaches the specific diabetic patient hiding in a tent before they go into a fatal coma?
That's the real challenge.
You can parachute 1,000 standardized NCD kits into a disaster zone, but if you don't know exactly how many diabetics just crossed the border, you are dropping them completely blind. This brings us to the operational blueprint for the whole endeavor, the HEPR framework.
HEPR stands for Health Emergency Preparedness, Response, and Resilience. It's a comprehensive strategic framework developed by the WHO to take the chaotic, unpredictable environment of an emergency and organize it into actionable, manageable components.
So it relies on what they call the 5 C's.
Yes, we start with the absolute foundation,
Yeah.
governance and financing. But the first operational C, the one that drives everything else, is collaborative surveillance.
Now, surveillance sounds a bit like a spy movie, drones and wiretaps. But in the context of global public health, surveillance is entirely about data. It is the lifeblood of response. The framework stresses that it is absolutely critical to include NCD indicators deeply within National Health Information Systems, or HIS.
You have to aggressively track key risk factors in the population. You need hard numbers on diabetes prevalence, hypertension rates, and even behavioral data like smoking status.
Because without that granular data, as you said, you are flying totally blind in an emergency. Imagine trying to procure a 3-month supply of life-saving, temperature-sensitive insulin for a massive, newly displaced population.
If you do not have solid surveillance data telling you exactly how many diabetics just crossed that border, you face 2 lethal outcomes.
What are they?
You will either order way too little, resulting in severe stockouts and preventable patient deaths, or, out of panic, you will order way too much, resulting in massively wasted financial resources and expired medications that could have been used to save lives elsewhere.
Neither is good.
Exactly. Effective surveillance involves synthesizing multiple streams of data. You combine aggregated, facility-level data, what the local clinics are seeing day-to-day, with comprehensive population surveys. The WHO uses something called STEPS surveys, which is a standardized sequential approach.
How does that work?
Step 1 is a questionnaire about lifestyle. Step 2 involves physical measurements like blood pressure, and Step 3 takes biochemical blood samples. By combining routine clinical data with these deep dive surveys, and even deploying rapid mobile phone surveys, health officials can paint an accurate picture of the true burden of disease.
The sources provide 2 amazing, highly contrasting examples of how this data changes the game on the ground. Let's look at Yemen first.
Okay, Yemen.
Yemen has endured one of the most intense, infrastructure-destroying conflicts of the modern era. Yet, during the height of the conflict, the public sector primary care system actually managed to successfully integrate NCD services. They managed to open 12 dedicated NCD clinics.
Which is incredible.
And the secret to their success was that they aggressively strengthened their digital surveillance using a platform called DHIS2, which stands for District Health Information Software.
I really want to emphasize how incredibly difficult that is. Implementing a digital interconnected tracking system like DHIS2 in the middle of a brutal conflict zone where the electrical grid is destroyed and internet connectivity is constantly severed is an absolute marvel of health informatics.
Because it works offline, right?
Yes, DHIS2 is open source, and it is designed to work offline. caching data on local devices and syncing the moment a brief internet connection is established. The payoff for Yemen was immense.
Because they utilized this system, they had ironclad data capture. They weren't just guessing. They could prove to the exact decimal point how many patients they were treating, what medications were consumed, and what the clinical outcomes were.
And that data facilitated their funding requests.
I think this is a huge takeaway. Data isn't just for academic spreadsheets or internal reports. In the humanitarian world, data is literally a magnet for funding. Donors are risk-averse. They want to know their money is actually working.
Yep.
By proving the need existed with hard, verifiable numbers from DHIS2, the health officials in Yemen built deep donor trust. They convinced those international donors to keep the money flowing, turning what was initially just a small pilot program into routine, sustained, life-saving care, even with a war raging in the streets outside the clinics.
We see a similar, incredibly innovative, data-driven success story in Bangladesh, specifically regarding the forcefully displaced Rohingya population living in the massive camps in Cox's Bazar.
One of the largest, most densely populated refugee settlements on Earth.
Yes. There, the Ministry of Health, recognizing the shifting demographics, supported a specific STEPS survey targeted directly at assessing NCD risk factors among the refugees.
Having that specific, localized data allowed the health sector to execute sustainable, highly accurate, bulk procurement of medications. They didn't have to guess how many blood pressure pills to order. The STEP survey told them the exact prevalence rate.
And what's really brilliant about the Bangladesh example is that they didn't just extract data from the population. They used the data to innovate how they interacted with the patients.
Oh, the pictorial feedback.
Yes. They recognized that they were dealing with a population with specific language and literacy barriers. So they included pictorial patient feedback mechanisms.
Patients could provide feedback on their care using standardized pictures and symbols, and the clinics tracked that feedback in their quarterly monitoring reports. It created a perfect, respectful loop of data collection, clinical action, and patient feedback.
But as crucial as it is, data collection and intelligent medication procurement are really only the first part of the equation.
Right.
Once you have the data telling you what you need and you have physically procured the drugs, you actually have to deliver the care safely to the patient, ensuring that the final mile of the supply chain doesn't break down when the environment is openly hostile.
This leads us seamlessly into the remaining pillars of the 5Cs framework: community protection, access to countermeasures, and emergency coordination. Let's start with community protection.
This pillar is all about empowering the people who are already on the ground inside the crisis. We are talking about training local community health workers, utilizing peer educators within the displaced population, and really leaning into digital health innovations.
There is a deeply impressive example of this from Sudan. During the COVID-19 pandemic, when physical clinics were shut down and transportation was paralyzed, the Ministry of Health and the WHO collaborated to set up a telemedicine hotline specifically dedicated to NCD patients.
It wasn't just an information line. It was a real clinical tool. The hotline was staffed by actual family doctors.
It allowed these physicians to provide clinical triage, adjust medication dosages, offer treatment advice, and provide psychological counseling directly to patients via simple mobile phone calls.
It brilliantly bridged the massive physical gap created by the lockdowns and service disruptions. And importantly, by providing a direct line to a doctor when everything else was shut down, it built immense community trust in the primary care system.
I have to admit, when I first read the Sudan example, using telemedicine in the middle of a severe emergency, it felt almost counterintuitive to me.
Why is that?
Well, when a country's physical infrastructure is failing, when the power grids are notoriously unreliable, and when basic services are disrupted, how can we possibly rely on complex mobile networks to deliver life-saving healthcare?
It is a common assumption that digital infrastructure is more fragile than physical infrastructure. But if we look at the reality of disaster engineering, it is often the exact opposite.
Really?
Yeah, mobile networks and cell towers often recover significantly faster than physical infrastructure like roads or bridges. A bombed-out highway or a bridge washed away by a flood might take months or even years and millions of dollars to rebuild, making it physically impossible for a patient in a remote village to travel to a hospital.
Okay.
But a damaged cell tower can often be repaired or temporarily replaced with portable diesel-powered generator units in a matter of days. Furthermore, simple voice calls or text-based USSD codes require very little bandwidth compared to modern internet.
So telehealth becomes an incredibly resilient, robust model of care because it entirely bypasses the physical barriers of a crisis. It leaps over the broken bridge and reaches the patient exactly where they are.
That makes total sense when you frame it like that. The invisible digital road survives long after the physical asphalt road is destroyed.
So you have the doctor on the phone with the patient. But the next C is access to countermeasures. This is about building resilient, legally protected supply chains so that when the doctor prescribes a medication over that phone call, the patient can actually get it.
The Philippines provides an absolutely stellar, proactive model for this.
The Philippines is an archipelago that deals with severe natural disasters, primarily massive typhoons, on an annual basis. Because extreme weather is a guaranteed part of their reality, the government has developed an essential medicines list that is specifically tailored to emergencies.
But this isn't just a laminated piece of paper. It is a policy document backed by intense regulatory mechanisms.
Right. The documents explicitly note that the Philippine government has mechanisms in place to activate emergency powers to control medication prices during a disaster.
They legally cap the prices, protecting vulnerable patients from predatory price gouging when demand spikes.
And even more practically, they alter the dispensing rules. If the meteorological department warns that a massive Category 5 typhoon is approaching, a diabetic patient can legally go to the pharmacy and get a much larger buffer stock of their daily pills.
They are permitted to hoard a multi-week supply so they can safely ride out the storm and the subsequent infrastructural collapse without running out of their life-saving medication.
Which perfectly illustrates why none of these pillars can stand alone. You cannot execute a nationwide telemedicine network in Sudan or legally adjust medication regulations and price controls in the Philippines without massive multi-sectoral collaboration.
You have to coordinate the Ministry of Health with the disaster management agencies, the private pharmaceutical industry, and international non-governmental organizations.
Which brings us to the final C, emergency coordination. The ongoing crisis in Ukraine serves as a powerful, real-time example of this coordination in action. When the Russian invasion began in February of 2022, creating massive internal displacement and millions of refugees overnight, the Ukrainian Ministry of Health didn't just default to the old model of only treating trauma and war wounds.
No, they rapidly, almost immediately, identified NCDs as a critical, life-threatening unmet need.
Their speed was remarkable. They immediately set up a dedicated NCD technical working group under the umbrella of the country's health cluster system.
By engaging incredibly early with the global pharmaceutical industry and professional medical associations across Europe, they were able to prevent a complete catastrophic breakdown in complex care.
They rapidly secured new, safe supply lines for temperature-sensitive insulin, routing it through neighboring countries. And astonishingly, they managed to sustain complex, highly vulnerable treatments like renal dialysis for thousands of patients despite the active, ongoing conflict and the constant targeting of their power grid.
It is truly incredible. They essentially built an invisible logistical shield around their most medically vulnerable citizens while under active fire.
If we pull back and look at the grand architecture of everything we've discussed, the rigorous data surveillance in Yemen, the resilient telemedicine networks in Sudan, the proactive supply chain regulations in the Philippines, and the high-level international coordination in Ukraine, we are looking at the foundational blueprint for the future of global health security.
It's all connected. A community hotline in Sudan is completely useless if the medicines at the local pharmacy are too expensive to buy.
And those affordable medicines cannot be physically distributed in a war zone in Ukraine without high-level coordination with pharmaceutical companies and military logistics. Every single piece of the system has to talk to the other.
It has been a profoundly eye-opening journey today. We started by completely shattering that narrow Hollywood image of the trauma surgeon, and we looked at the shocking, undeniable statistics.
74% of global deaths are from NCDs, and millions of those people are trapped in decades-long displacement, effectively living their entire lives in the crosshairs of a crisis.
We waded through the agonizing, complex, ethical choices of triage, exploring how doctors are forced to decide who gets life-saving care when the insulin runs dry.
And we looked at the incredible, innovative solutions the global community is desperately building. The mathematically calculated NCD kit, offline DHIS2 tracking in active conflict zones, and doctors delivering care over cell phones when the hospitals are gone.
Whether you are a student trying to understand the reality of global health trends, or you are a professional prepping for a high-level policy meeting, you now know the operational truth.
True emergency response isn't just about pulling someone from the rubble and surviving the initial terrifying disaster. It is about surviving the Tuesday after the disaster. It's about surviving when the adrenaline has faded, the news cameras have moved on, and your daily life-saving medication is down to the very last pill.
I think the ultimate takeaway is that the shift from acute, short-term aid to managing chronic, complex diseases in the world's most difficult, unpredictable environments is not just a logistical challenge. It is the defining challenge of modern humanitarianism.
It forces every single one of us to deeply reevaluate what it actually means to save a human life in the 21st century. And as we wrap up this deep dive, the sources we've explored leave us with one final, deeply profound realization to mull over.
Yeah.
Humanitarian crises are no longer just happening over there in distant countries. They're increasingly caused or massively magnified by the accelerating reality of climate change.
We are looking down the barrel of a future with more extreme, prolonged heat waves, more devastating flooding, more severe droughts, and inevitably more armed conflicts over disappearing agricultural land and water resources.
As climate change forces the migration of larger and, importantly, much older populations from coastal urban centers, populations that are entirely biologically dependent on complex refrigerated medications, CPAP machines, and daily handfuls of pills, we have to ask ourselves, will our current global supply chains actually hold up?
It's a huge question.
Think about your own neighborhood right now. If a massive, unprecedented climate event hit your city tomorrow, knocking out the power grid and making the roads completely impassable, how long would your own community's medical buffer stock last? How many days until the pharmacies are empty? At the beginning of this deep dive, we talked about that Hollywood image of the trauma surgeon running in to fix a clear, visible, bleeding wound. But as we've learned today, the real crisis of the future doesn't bleed. It sits quietly in a displaced person's tent, or perhaps in a flooded apartment building, waiting for a pill that might never arrive. Thank you for joining us on this journey into the realities of global health. Stay insanely curious, and we will catch you on the next deep dive.